share with you the latest and greatest in all things fertility and try and dispel the myths and explain all the realities of infertility. So welcome to our show. I'm Dr. Rahi Victory. I'm a reproductive endocrinology and infertility specialist. And next to me is my good friend Tariq Ibrahim from Ibrahim Strategies Group, who does all the social media for Victory Reproductive Care. So thank you for joining us. Normally, we spend the first 20 minutes of the show talking about an exciting new paper or article, except this week had no excitement. There was really nothing to talk about. So I thought we would just review any questions that you had. And we put a request out for questions and we got a bunch. So we can go over those as well. So you can start asking your questions anytime. And with some luck, we'll finish on time this week and go from there. So hopefully everybody's had a good week and everything's been going okay. It's starting to get a little bit cooler in our part of the world here. So we're dealing with cold rain and wet roads and slippery surfaces. Our practice is quite excited because we are just about to complete our final inspection from the College of Physicians and Surgeons of Ontario. And so we're excited to have that out of the way. God bless my amazing team of staff who have been working tirelessly on this, in particular Lisa and Mara, who have gone completely above and beyond to get this all done. So thank you, ladies. I love you. And hopefully everybody is enjoying the fact that COVID finally seems to be settling in some parts, especially around us here. And hopefully we're going to return to some sense of normalcy in the not too distant future. So that's been exciting as well. And I am happy to take questions. Have we already got some? All right, fire away.
Is there any benefit for male fertility to take a huge amount of antioxidants? Vitamin C, 10,000 milligrams a day, vitamin D, 10,000 IU a day, vitamin E, 3,000 IU a day, keratin 10 milligrams a day, and
Selenium.
Yeah.
So no one's looked at those huge mega doses. I'd probably shy away from using mega doses. You can get even vitamin toxicity. There is an upper limit to how much of each vitamin is necessary or valuable. So that's probably overkill in some instances. Nevertheless, that's probably something to take up with a naturopath. They have a little bit more experience in that area. The whole idea of antioxidants and sperm is actually quite controversial. There are many studies that show a benefit, and actually there are some studies that show that it doesn't help at all. In fact, there was a recent study just last week that suggested that a specific grouping of antioxidants did not help for male sperm. So I certainly wouldn't be using massive doses. And the most important thing with antioxidants is to not have an oxidant that you need to use an antioxidant for. So in other words, if you're smoking, drinking, using drugs, your weight's really high, you're fighting diabetes, you're chronically exposed to plastics, chemicals, fumes, that kind of thing, that's not going to be good for your sperm. And no matter how many antioxidants you take, the oxidative damage will always far outweigh the ability of the antioxidant to correct it. So make sure you're correcting all of the parts of your diet or exposures or environment that are contributing to the high levels of oxidation before you go ahead and just start treating with the antioxidants.
I asked my RE if I should take baby aspirin, and I was told that I didn't need it as they recommended for those over the age of 40. Any harm in taking it? No blood thinning issues?
No, so we have a great post or video on aspirin. It's actually one of the more popular ones on our YouTube channel. So go to YouTube, click that subscribe button, and make sure that you join on there and have a look. But we have a good video on it. It's got a lot of benefits. It reduces preterm labor. It reduces the chances of preeclampsia, high blood pressure. It's likely good for things like intrauterine growth restriction. It can decrease inflammation. So the idea that it's only good for women over 40 is not based on any science. That's never been something that they've specifically looked at. So there are many studies that have shown a benefit to using aspirin, and so that's why we use it. So don't listen to your RE, go ahead, as long as it's safe for you and you don't have any contraindications to taking aspirin. then it should be fine for you. If you do have any contraindications or you're not sure, make sure you follow up with a physician.
Hi, Dr. V. I'm doing my transfer in the next few weeks, and I'm wondering if I should get the flu shot now or wait until after the transfer.
Yeah, I'd probably wait till after. I'm not a big fan of activating your immune system right around the time of an embryo transfer because you want a relatively calm, quiet immune system. So flu shot can cause some immune reactivity. If it's like a month away, 6 weeks away, you're probably fine. But if it's just a week or two away, I'd hold off.
What is the perfect diet for males to boost fertility, and what are the top 5 fertility boosting foods and supplements?
Wow. So I don't know that there's a top 5, but we can tell you that in terms of supplements, a good antioxidant vitamin. So something like we use ProFertile or Fertile Pro, but any of the brands are fine. They all are going to have CQ10, which has been proven to be beneficial for sperm, folic acid, which is proven to be useful. Vitamin D can be very helpful. Zinc has been proven to be beneficial. There is some evidence that some of the other elements can be helpful as well. And many vitamins and supplements are necessary to maximize the performance of the sperm. L-carnitine, L-arginine, these can be helpful also. So there are numerous different things that can go into it. Vitamin C, D, and E are all really good, strong antioxidants. So all of those can really help. In terms of diet, you want a diet that is low in calories generally. You want one that's definitely low in sugar, low in cholesterol. If your weight is an issue, you want to bring your weight down. You want to exercise on a regular basis. All of those are critical.
Question from Instagram.
Sure.
Hi. Before an FET, would it be reasonable to do fertility as a precaution? I'm 39, never been pregnant, and have 2 eukaryotic embryos, and want to make sure all is okay before I transfer.
Yeah, that's a great question. I love that question. So lots of thumbs up and likes for that question. Because you only have 2 embryos, it is probably worth the cost to do the testing, because at worst you find out you're normal and you wasted a little bit of money, but at best you find out that there was something wrong and you needed it to be treated. So yes, that is something I would consider doing if you are 39 and only ended up with 2 euploid embryos. It's going to be a lot cheaper to do a fertility test than it is to do a whole new cycle of IVF. So I would be supportive of that in your particular case. That makes good sense to me.
If a lead follicle is 23 millimeters before a trigger shot, is it over mature?
It depends on what's happening with the rest of the follicles. So if you have a number of other follicles that are present that are reasonable size, 23 is getting a little long in the tooth. It still may be okay. We typically want to trigger a little bit before that, but it also depends on IUI versus IVF. We go a little bit farther usually with IUI than we do with IVF. So with IVF, we're looking around 18 to 20 typically. And with IUI, we're looking like 19 to 21. But sometimes you have to allow the follicles to go a little bit longer to get some more follicles. And so sometimes it's okay to have 123, but then have, for example, a 20, a 19, an 18, a 17. So it all depends on what the overall picture is, not just one.
What protocol do you suggest for a poor responder with low AMH and endometriosis? Puragon and Minipure along with Cezanne didn't work well.
So the stim part of it really is the most important part in terms of what agent are you using to prevent ovulation or to suppress ovulation. So in our hands, we find the best results with a Lupron flare protocol, a microdose Lupron flare protocol. I like that one the best. They have head-to-head compared all the different types of stim. So estrogen priming, testosterone priming, microdose flare, antagonist, letrozole, Clomid, they all have the same outcome. So you may need to try a couple of different variations for you. With the fact that you have endo, microdose flare probably makes a good deal of sense because you're going to get some of the suppressive effect of the Lupron plus the boost effect of the Lupron. So I like that for you because of the endo. That would be a very reasonable approach to things. And I think that would probably yield you good results. You want to be on NAC, you want to be on coenzyme Q10 and curcumin or turmeric powder, supplements that are really helpful for you if you have endometriosis. And then as well, sometimes DHEA can be beneficial. Seisin does not increase the number of eggs you have. It just increases the number of mature eggs that you might have. And it's never been shown to increase live birth. DHEA actually has been shown to increase live birth. Again, we have a video on that a few months ago. We reviewed that study. And just go to YouTube, click the subscribe button, and like and comment. Make sure you jump on there and check that out. We've got a great video on that you can find out about for DHEA.
Next question.
They're all over the place now.
Yeah, they're all over the place. What is the perfect diet for males to boost fertility? Oh, we did that one. Does using Adderall as a prescription drug for males reduce pregnancy outcomes, and does it lower fertility or quality of the baby?
Yeah, we don't know yet for sure, although I can tell you that we have seen significant alterations in both sperm and egg quality in people taking Adderall. So I definitely would not recommend it. If you must be on it, that's a different story. But if you can avoid using it, or you're using it for enhancement because of studying or academics or whatever the case is, I would strongly recommend getting off of that. So yeah, Adderall is probably not optimal. Certainly it can increase prolactin levels. And if it's interfering with your prolactin, that can definitely interfere with things. So I would be cautious in that regard. But generally speaking, we shy away from letting people use any of those types of medications when they're going through fertility treatment, because it's likely going to have a negative impact on things. I'm going to be talking all night now, so I gotta.
Yeah, you get ready.
I need my tea.
We were successful with our first IUI with you.
Great.
Thank you.
You're
and I
welcome.
have a beautiful 8-month-old baby girl.
Aw.
When
Nice.
would you like one or more to complete? We would like one more to complete our family. When
Sure.
doing that, we just hold on.
It faded away.
Yeah, hold on. When doing that, when doing that, we would. When we're doing that, we just get a new referral to see you. Should there be any amount of time that we try on our own first? I have PCOS.
Yeah, I mean, if you're not breastfeeding and your periods are regular, then you can try for 6 months or so. It depends on your age. If you are breastfeeding, then it's extremely difficult to get pregnant, so I would recommend stopping. And if your periods are irregular, regardless of whether you're breastfeeding or not, then it's not going to work. You need help. So come back to us sooner rather than later. Yeah. Anytime you're looking at the breakdown of when to see a physician, it's simple. Under 35, regular periods, wait a year, unless you know that there's something wrong. If you don't know that there's something wrong, try for a year, sex every 2 days, nonstop through the whole month, lots of vitamins, lots of supplements, eat healthy, no smoking, no drinking, no drug use. If you're over 35 and your periods are regular and you're under 40, then you can do it for 6 months. If you're over 40, it's only 3 months. If your periods are irregular, they're not coming regularly, you should be seeking help immediately. There's no point in waiting. So that's how we break down the different groups, 4 groups. So less than 35 regular, 35 to 40 regular, over 40 regular, and then the whole group, no matter what your age is, where you're irregular. Those patients should seek help right away.
I just did a second FT Thursday after a failed one in July. No symptoms yet besides regular cramping, presumably from the progesterone suppositories, which is the same as last time. Any concerns?
Progesterone suppositories should not be causing cramping, but cramping in and of itself does not cause us any concern. Lots of people react differently, so we don't get too nervous about cramping per se.
Is there a protocol for athletes for sperm freezing before they start taking PEDs, anabolic steroids?
Ooh.
And is there a protocol for athletes after using PEDs for full fertility recovery?
So you should never use anabolic steroids. If you have to for whatever reason, and I can't imagine one, but let's say you do need to use it, then you should be freezing sperm ahead of time. So stay away from steroids. Make sure you haven't used it for quite some time. Ejaculate regularly, lots of vitamins, no smoking, no drinking, no drug use. And then you can keep your sperm frozen. If you're going to use anabolic steroids, using some HCG in addition to the anabolic steroids, plus minus arimidex or letrozole, can help reduce some of the negative impact, but there's no guarantee. Remember that those anabolic steroids actually shrink your testicle, and you can't always recover the testicle after it's been shrunken. So I strongly would caution you about using anabolic steroids. It is not good for your testicles or your fertility under any circumstances.
Hi. Stopped trying for a baby, but would like to continue to track and trend hormone levels as I'm 41 and want to approach menopause with ease. Would I see my gynecologist for this or seek a RE?
A good gynecologist will know what to do. I guess it's a matter of what constitutes a good gynecologist. So if you have a knowledgeable gynecologist, it shouldn't be a problem. If you don't have a knowledgeable gynecologist, you can definitely see an RE. If you're in Canada, then it's pretty easy because REs help with menopausal symptoms and with fertility care. In the States, it's actually harder to find REs that deal with the menopausal component because they're all way too busy trying to make everybody do IVF. So it's a little more difficult in the US than it is in Canada.
What causes fluid in the line? If you had a hydrosalpinx that was removed from the uterus, is fluid in the uterus still a concern during FET?
Yeah, fluid in the uterus is universally not good. So number one source is probably what's called an isthmocele, which is when you have that little steeple-shaped defect where a C-section scar is, and it produces or collects old blood and infection, and then that creates fluid. Number two would be a hydrosalpinx or a very tight cervix. So your cervix can be stretched open. If you had a hydrosalpinx and they removed it, I'd be wondering if the other side has a hydrosalpinx as well, which is very possible. Infection is the other source, whether it's in the uterus or in the tube. And then very, very rarely we just get patients that have bad, tubal disease or tubal status or just fluid in the uterus and we don't have a reason for it. And for those patients, we don't really know how to fix that. I've tried everything, antibiotics, drainage. You can drain the fluid out with a biopsy kind of catheter the day before. By the time you bring them in the next day to do the transfer, the fluid's back there again. So it's quite difficult to get rid of that fluid in certain circumstances. So explore all the possibilities. If you have had a C-section, almost certainly it's coming from the isthmocele. There are different ways to deal with an isthmocele, and that's probably how to start.
I'm wondering if a sonal test can show blocks too, but perhaps an HSG could show something different.
Yeah, I mean, the saline infusion sonohistogram is a great test, and I love it, and I'm a big supporter of doing that before you do an HSG. But there are some patients where we can't tell from the SIS if the tubes are open or not, and those patients need an HSG. Not to mention, depending on how uncomfortable it is, sometimes the tubes will spasm. And so if it's real painful when you do the SIS, the tube can spasm and prevent you from getting pregnant. From having the tube open and knowing if the test is valid. Whereas with an HSG, it also can spasm, but frequently if you do it long enough, you'll see the dye go through the tubes.
Is it impossible to impregnate your wife as a man with teratospermia or azoospermia?
If you're azoospermic, then it's impossible because it means you have no sperm. Teratozoospermia means you have abnormal sperm and very few, but not necessarily zero. So if you're talking about azoospermia, it's a huge issue. You will not be able to impregnate your wife naturally. And even if you have borderline azoospermia where there's very few sperm, it can be very, very difficult. Not impossible, but difficult. Excuse me.
Would you recommend canceling the cycle if the largest follicle is 9 millimeters on a day 9 or 10. I'm afraid if I continue the cycle will be longer. Last time, very long cycle, had no normal among 4 embryos.
Yes, absolutely cancel. That's a waste of time. You're not going to get anything out of that. You've got maximum 3 days left before you can pull the trigger. You're not going to grow a 9 to the right size in 3 days. So stop that cycle, go back to basics, try something different.
I had an endometrium biopsy without medication, and my period has came 7 days early. Is this normal after a biopsy?
No. No.
Sometimes it's one word.
Yeah, sometimes it's just a one-word answer. No, an endometrial biopsy should not initiate a period unless you had a very unstable lining because it was overly thick, or your PCO, or you've had postmenopausal bleeding or something like that. Otherwise, it should not trigger bleeding. Yeah, I guess if you had a polyp or a fibroid, it could do it as well.
Following up on the Fertility question,
yeah.
Which test do you recommend?
Yeah, so I kind of like their full test. It's expensive, and I hate that. So we kind of negotiated a deal with them through our clinic to give our patients better prices. I don't get anything from Fertility, and we don't charge you. You just use our name, and they give you a better price. But we like the full test because there are sometimes extra things we need to adjust either in the vagina or in the uterus in order to maximize your chances. So the full test gives you all of that. The basic does not give you all of that.
I'm CD8 of my FET cycle. Been taking letrozole and Z-Pak for 4 days.
Yep.
I'm experiencing bleeding today after 3 days of no bleeding.
Yeah.
Should I be concerned about this at all?
We'll have to see what happens with your lining and then figure it out from there. So make sure that you let the girls know, and we'll figure things out. Certainly if the lining develops, it's not a concern, but that is unusual. So we would want to make sure your lining's developing properly. So that's blood work, ultrasound, things like that, and that'll help us figure it out.
I usually spot for days a week to my monthly flow, but this month spotting occurred earlier on day 13, 29-day cycle. I've been trying to get pregnant for 14 months. Could this be a cause for the delay?
Yeah, I mean, if you have a fibroid or a polyp, it could cause all of that, or if your hormones were wildly out of the norm. So any of those things could contribute. So make sure you're getting all the testing done to know what's wrong. So if you have a fibroid or polyp, it may need to be removed, in particular if it's on the inside part of your uterus for a fibroid. If it's a polyp, it's easy to remove. If your hormones are not doing what they're supposed to, you need to address that, whether it's your thyroid or your FSH, LH, prolactin, and so on. So definitely an indication to get seen. It's been 14 months. You've tried long enough. Make sure you get seen and get tested.
Do you have a recommendation for an RE in Edmonton?
Me. I'm not in Edmonton, but we have plenty of patients that come to us from Edmonton. I only know of one RE that's in Edmonton. I don't know him. I know him. I don't know his practice well enough to know how good he is. He recently joined PCRM. I don't know them well enough to say whether or not you should see them, but we help people from all over the country, so we're happy to help you out. The folks over in Calgary are pretty good. I really just don't know how good the Edmonton PCRM location is. So I don't want to say anything positive or negative about them. I just don't know.
We had an IUI last Friday. I'm not due for my period until November 2nd. However, last night I began spotting. Today is full blow and flow. What could this possibly be? I'm only 10 DP IUI.
Abnormal cycle or a very big implantation bleed. Make sure you're not on any blood thinners. If you are, stop. That could be just a huge implantation bleed potentially, or you just had a very abnormal cycle. So anything's possible. Make sure you get seen, though. We don't want to take any risks. It could even be something like ectopic, although that's very, very early. So get seen for sure.
Any special tests I should ask for after 3 unsuccessful FET? 1 ended in a miscarriage, 2/3 both negative betas.
Yeah, get everything tested. So your chromosomes, his chromosomes, DNA fragmentation, fertility testing for your immune function and for your menstrual blood to see if it's got infections in it, thrombophilia screen, hormone testing, saline infusion sonohistogram. Like there's a whole trainload of tests you need.
So for the previous question about the bleeding, she says that I am on blood thinners.
Oh, well, if you don't need your blood thinners, you should be stopping your blood thinners because you probably just had an implantation bleed and it's going on and on and on. So if you need your blood thinners, don't stop your blood thinners because I don't want to mess with your health. But if you don't need the blood thinners, stop the blood thinner until the bleeding settles.
During my sono, the doctor said I had a very enlarged right ovary and that it actually drops over to where the left one should sit. Left was removed. Do you know what would cause this? And is it something to be worried about? I do have PCOS.
No, it could just be the PCOS. PCOS women have bulkier, bigger ovaries. So it's entirely possible that that's the only problem. Yeah.
In a medicated uterine biopsy, 23 days, it would be normal to
Medicated uterine biopsy?
Yeah.
Okay.
I just.
I know you just read.
I never asked.
Right.
So any medicated uterine biopsy, 23 days.
Yeah.
It would be normal to start a period 3 days after a biopsy.
Not sure what a medicated uterine biopsy is unless you were doing an ERA test. You may get spotting and bleeding. On the flip side, if you stopped all your meds, yes, you would get bleeding 3 days later. So if you stopped your progesterone, anytime you stop the progesterone, roughly 3 days after you stop, you should get bleeding. So maybe that answers your question. I'm suspecting you were doing an ERA test. You stopped your progesterone and estrogen after they did the biopsy. You would get bleeding 3 days later.
Big question.
Big question.
Yeah.
Should I read it or do you want to read it?
No, that's okay. I can handle this.
Okay.
I just want you to be able to handle it.
All right, I'm ready. I'm ready. Bring it on.
I heard that some components of mitochondria get affected if the stim cycle is longer. Would you mind explaining, is there a relationship between longer cycles and abnormal embryos?
There is. So the longer your stimulation goes, the poorer the egg quality and the lower the chances of success. In particular, while mitochondria, we don't have direct data for that I'm aware of. There is direct data for smooth endoplasmic reticulum. There's a much higher percentage of aggregation of the smooth endoplasmic reticulum in your embryo's cells when you have had a prolonged stim phase. So it is critical to avoid that because once you have the aggregates of the smooth endoplasmic reticulum, you're in trouble. So I would definitely recommend never going past 12 days of stim. If you go past 12 days of stim, you're wasting your time and money. Don't. It's extremely, extremely rare that you'll find success. And it's a waste of money. You need a different protocol to try and stimulate the eggs to be ready earlier, or even go for the eggs earlier and hope that they're mature. You can try using Sizin to help that, human growth hormone, but do not try going for 14, 15 days. I've had all sorts of people say, oh, I was being stimmed for 17 days, 15 days, 14 days. That's just a waste of money and time, guys. Don't do that. You'll get terrible egg quality out of it.
Is pregnancy-induced hypothyroidism truly random? Does it usually go away after pregnancy?
There is a natural hypothyroidism that is part of pregnancy, which is why so many women need more thyroid hormone when they're pregnant. But it's not clinical hypothyroidism. So most women don't develop actual hypothyroidism in pregnancy. You just see their TSH kind of climb. And that can be symptomatic or it can be asymptomatic. So it depends on the patient. There's no formal disease sort of called pregnancy-induced hypothyroidism.
I have there's a follow-up answer to your.
For my ERA, was I right?
You are right.
I was right.
Yeah,
Yes, I love it.
It's an ERA cycle with biopsy.
Yeah. So, like I said, you were doing an ERA. So you took estrogen, then you took your 5 days of progesterone, then hopefully you waited a day, and then you did your biopsy. Probably continued it another day, and then did another biopsy the following day. So, because you were on estrogen and then took progesterone and then stopped your progesterone, you will get bleeding. That's normal.
Is there anything you can do to improve sperm morphology?
Yeah, no smoking, no drinking, no drug use. Keep your testicles cool. Ejaculate every 2 days. Eat healthy. Make sure that you are not overweight. Make sure you're not putting pressure against your testicles. All of those things are important. Take tons and tons of vitamins.
What would you adjust if you got SCR after a 12-day stim?
The 12 days. The shorter the stim, the less chance you'll get SCR. So you want to do it faster. It's better to have 2 or 3 good eggs than have 10 lousy ones. All too often, we are trapped into the mindset that we need lots and lots of eggs, when in reality, we just need a couple of good ones. So you're much better off getting a few good eggs than lots of not good eggs. So this duration of your stim is important. We have a Instagram post on that. I don't think I presented the article, but there was a post on it going back months ago. I want to say probably 4 months, 6 months ago. So you can look that up and find out what that showed, because we demonstrated a study in that post that reviewed the fact that the SCR significantly decreases your success, and it was directly linked to the duration of stimulation. So make sure that you check that out. Did we do a video on that?
I don't know.
I don't think so.
I'm trying to remember. I don't know.
I don't think we did, although it was an interesting article. Anyways, yeah, check that out. Maybe that's one we do next time. We could do that. Yeah.
I know aspirin is part of your protocol.
Yeah.
Can it be beneficial even without knowing clotting issues? Does it improve chances of an FET success?
Yes, I believe so. There is some data to support that, but what's most important is it makes your pregnancy less complicated, less preterm labor, less hypertension.
I'm assuming it's of no concern if you don't have any symptoms during the 2-week wait after an FET?
No concern at all. Yeah, it's totally normal. It's too early. Like, most women don't know that they're pregnant until they're late for their period and then after. So if it's just during that 2-week wait, you're too early to know if there's any symptoms or problems. The questions just keep coming, huh?
Yeah. Hi, Dr. Victory. I have a history of stage 4 endo and tubal ligation. I have a history of 2 failed transfers, 1 with OE and most recently 1 with DE. Embryos are normal, PGTA tested. My doctor is not concerned about the endo.
What?
Hold on, it keeps scrolling. My doctor is not concerned about the endo, but after 2 failed implantations with normal embryos grade 4 AA,
wow.
I'm concerned and afraid to move forward with another transfer. She doesn't know why it didn't work because my lining and everything looked good. The only thing concerning was that I developed fluid from the estrogen, but it had cleared up before transfer. I was about to do an ERA, Emma, and Alice test until watching your show. For my last transfer, I used the DCP, estrogen, progesterone, PO, and suppositories. This time, she thinks we can go back to the old school protocol using Lupron. Please give me your input as I am lost.
Okay, so you should not be doing most of what they're doing and doing a whole bunch of stuff that they're not doing. So first of all, you need Lupron and Letrozole for 3 months to suppress your endo, plus minus surgery if there's endometriomas. Anyone that says that endo does not impact success just simply doesn't know what they're talking about. So endo very directly reduces your success. So you either have to surgically treat it or you need to medically treat it, or both, but doing nothing is clearly not a good idea. Number 2, you want to use the absolute least amount of estrogen possible, because The minute you start using estrogen, you're actually stimulating your endo. So you want to avoid stimulating your endo completely. It is imperative that you manage to avoid stimulating the endo. So you want to use letrozole instead to hopefully just make one natural egg grow. And then if you need any estrogen, a minimum amount, and ideally vaginally rather than orally, so that your systemic estrogen levels are low. Progesterone is useless orally. That's been proven time and again. Again, we have a video on that just recently. So make sure you check out that video on the YouTube channel. It was one of our recent Fact or Fictions about a month ago. So bottom line for that is you need to use vaginal progesterone and progesterone in oil. Make sure you're on all the supplements for endometriosis. So that's NAC, curcumin, and coenzyme Q10. There's a whole bunch of others you can try as well, but those are the main ones that we use. And so make sure you're on that stuff because that is critical to your success. It is not okay for someone with severe endo to be on a protocol that involves giving you tons of estrogen to thicken your lining. That's actually completely contradictory to common sense. So don't do that. For sure, don't do that. I would probably recommend adjunct therapy as well. You may want to consider things like intralipids, maybe a low-dose prednisone, Inahap, things like that, because the more you can do to reduce your inflammation, the better off you are. And with endo, you're inflamed. So you want to kind of mellow out that inflammation level.
Is it better to take regular aspirin or low-dose aspirin?
Baby aspirin, 81 milligrams. You don't need the 325. That's too much.
What FSH is considered too high for a day 3 to start stimming?
There's no FSH that's considered too high. The problem is, will you respond? So if your FSH is 14, 16, you're much less likely to respond. If your FSH is under 12, it's considered normal, so you're more likely to respond. So once you start going over 12, it's less likely that your ovaries are going to respond. Having said that, I had a patient, I want to say about 2 or 3 years ago, who couldn't decide what she wanted to do and kept doctor shopping between us and the US and I think another doctor, and kept going to each of us. And she kept coming back month after month after month wanting testing on day 3 to see what her FSH was. And I kept saying, like, it doesn't matter what your FSH is. You're wasting time, losing opportunity, waiting for something that can only actually get worse. And she kept hoping that with naturopathy and, you know, acupuncture and healthy diet and stuff, it would get better. But the reality is you can see changes, but it's extremely unlikely it's going to make a meaningful difference to your egg quality. So time is a much more powerful weapon against you than any of those other things are going to be beneficial to help you in this war. So don't try and wait for a number. Go ahead and try getting stimulated. Now, that's if your FSH is close to the 12. If you've got an FSH of 24, I mean, realistically, the chances are very, very slim. So waiting for a 22 versus a 24 makes absolutely no difference. Just go for it.
Hi, Dr. V. Thank you for hosting these Q&As. I just found out I'm pregnant a month before starting IVF. I'm 38, secondary infertility, and was trying for 1.5 years. Your videos have kept me insane.
Oh,
thank you.
Kept me sane.
Big difference.
Yeah, just rewind now. Well, I'm glad to hear that. Actually, just before we started the show, I got a lovely little baby picture from someone who said, thank you for everything you did. So they were successful too. So kind of cool. It's a very rewarding job doing what we do here. And even for Tarek and I, Tarek is now also responsible for lots of babies out there. So this is kind of cool. Yeah, and I don't mean that in an inappropriate way.
That needs clarification. That needs a lot of clarification.
Mirvet, if you're watching, it was strictly professional.
Strictly professional. Is there a good chance of a day 6 embryo having a reasonable chance if it's a 4BB?
Yeah, it's a great chance. It's normal. It's a normal chance. So A 4BB day 6 is a great embryo. We wouldn't hesitate to use that.
Does a day 6 embryo have a, oh, if it's 4BB, is 4BB better than 3BB? I got 3 day 5 3BBs and 1 day 6 4BB.
If you got a 4BB, that's better than a 3BB if they're both day 6. But if one's day 5, that's probably about the same.
There you go. Is it possible to request your baby's remains from a first trimester DNC in Ontario? If yes, what is the process? Need to prepare for burial.
It is possible. You can request your tissue. It'll probably have to go through pathology and then come back to you. There is no obligation to perform a burial, although I am fully respectful of your desire to do so. So yeah, you just ask for it and I'll return it to you. I got a personal message from the patient that had the bleeding. So yes, call the office tomorrow, but stop the medication for now. That's going to be complicated. Wow. Temporarily stop the heparin. Temporarily. Wait till the bleeding stops. Yeah. Oh, now it's my fault.
Yeah. Never mind. One embryo FET
Yeah.
split into 2.
Oh, cool.
Did not grow after 8 weeks.
Oh,
Miscarriage.
I'm sorry.
Any advice or suggestions for second attempt of one embryo left for FET?
Oh, God, follow all of our protocols, right? So healthy diet, make sure your weight is good. Make sure you're on all the vitamins and supplements we talk about on every show. Get your iron and your vitamin D level checked. Make sure your lining is good. Take very little estrogen. Use progesterone in oil and progesterone vaginal. Get your levels checked. Make sure the lining is appropriate. No smoking, no drinking, no drug use. Make sure you're not around any smoking. See how things go. Melatonin, all the good stuff.
Following up to melatonin,
okay.
What dose of melatonin
off camera
do you recommend?
Tarek was super excited about that.
I like when it does that. It's rare.
What dose of melatonin?
Yeah, and how long before the egg retrieval?
Oh, melatonin's never been shown to be beneficial for an egg retrieval. It's for your embryo transfer, frozen to be specific, and it's 3 milligrams a day. But if it's helping you sleep better at any point in time, it's probably going to be beneficial. So if you need it leading up to your embryo or your egg collection because you're nervous, that's fine. Go ahead.
My AMH is 12.49. Is that normal?
It depends on whether you're talking picomoles or nanograms, and I need to know how old you are. So there's no normal AMH. It depends on your age. It depends on which units we're talking about, what they've done to your ovary before. A 12.5 or 12.4 or whatever, AMH could be quite normal if you were, say, mid-30s, and that's picomoles per liter. If it's 12 and it's nanograms per mil, you have the strongest ovaries on the planet. So that would be excessively high. If it's 12 and you're 18, there's probably something wrong with your ovaries. So it all depends on where things sit. If you go, I never recommend people go online. But if you go online, they have nomograms showing average AMH levels and your age, and you can figure out where you should be.
What grade?
That's a good video?
That's a good video idea.
Go through what people should have? Oh, we could do that. Like a simple,
yeah.
Oh, like a YouTube video. Oh, I like that. That's a very good idea. All right, we'll do that. We're going to do that. That's a great plan. Okay.
What grade and stage of embryo is best?
What grade and stage of embryo is best? So we reviewed that actually on the show. So we have a video on the YouTube channel. Again, it's going back a few months where we looked at which embryo is the best one to transfer. So going into the freeze, it's a 4A down to BB. And coming out of the thaw, it's a 5 or a 6 before you transfer it.
My CoQ10 supplements are 200 milligrams each. I've been taking 2 a day. Is this enough for my FET?
It's 200 milligrams each,
Mm-hmm.
and she's taking 2 a day.
Mm-hmm.
No, you need one more. So it takes a total of 600. CQ10 does not absorb well at all. So unless you're using that product called Neo Q10 from a company called Theralogics, you need 600 milligrams. That particular product was so strong, you only needed 125, but it gave like 10-15% of our patients a rash, so we couldn't use it. And it stank. Like it was the most foul smelling thing I've ever been near. Yeah, it was bad.
Currently doing Duo-stim.
Awesome.
I have 3 follicles between 18 to 20 millimeters.
Okay.
At day 9 of stimulation during follicular phase, I have 9. 9 others at, breaking the question.
Okay.
9 others at 8 to 10 millimeters.
Yeah.
Will those be retrieved during the luteal phase retrieval?
Yeah. Those littler ones are the ones we're going to collect during your luteal phase retrieval. Yeah.
From a different clinic, we have 6 frozen embryos total, and 3 of them are graded as early blastocysts. What are the success rates for these gradings, for this grading?
That's not enough information. I would need to know more details. But early blastocysts obviously are not as strong as expanded blastocysts are. So I guess I would need to know why you have early blastocysts. If they were early on day 6, there's still a chance, but it's going to be lower than it would be with an expanded blastocyst. If they were early on day 5 and they just didn't wait till day 6, probably because of either technical reasons or they were just too cheap, then that's a different story altogether. So you may actually have had embryos that would expand, in which case, if you just wait long enough, they will. So I don't have enough info to answer that question. Sorry. I would need more information, like what day they were frozen on. You know, while we've been doing this, one of my patients has been sending me pictures of her baby that we made sitting on the back of a Porsche. So thank you, Nikki. That's awesome. She said, thank you, Dr. Victory, for changing our lives. So we love you. I don't think they offered to give you the Porsche. That's for sure.
Hey, Dr. Victory, just wondering if any food, drinks such as fruits and veggies to avoid during the 2-week wait and to avoid intercourse, as orgasm may irritate the cervix/uterus. Thank you.
Don't avoid orgasm. You don't need to. It's totally safe. It's probably in some ways beneficial because it reduces stress. Foods to avoid: high sugar, high cholesterol. So yeah, aside from that, you're fine.
What are the chances for someone with an AMH of 3.2 picomoles?
Unfortunately low, very, very low. So 3.2 picomoles, you're looking at maybe producing 1 or 2 eggs, 3 maximum on average. And so that would make it very, very difficult to be successful. Doesn't mean you can't be successful. Doesn't mean you shouldn't try or don't deserve to try, but that's going to be difficult. You would probably need to try several times. If you look at our embryo math video, your ovaries are behaving like someone who is in their mid 40s or even late 40s. So that takes a lot of tries before you hit the one normal embryo.
What would be your suggestion for the protocol for DOR, high dosage or low dosage stims?
You know, it depends. We frequently like to start with a high dose and see if we can prod your ovaries to do better. And if we can't, then we immediately lower it down and just let you take a lower dose because it's not working. So I don't believe in pounding people with 600 units of gonal-leptin Menopur for 12 days because it's not going to help you if you're only producing 1 or 2 eggs. So sometimes when I see people are only making 1 egg, I'll even stop the meds and just give you 75 of Menopur. So it depends on how things go and how many eggs you have at the start. So, if you have 6 or 8 at the start, yeah, sure, take a high dose. You want all 6 or 8. But if you only have 1 or 2, or only 1 or 2 of the 6 or 8 are responding, you don't need a lot of medication. You just need low dose medication. They'll still grow and you just go after them. Save yourself money, stress, probably has better impact on the eggs when there isn't as much medication.
Hey, Dr. V, your office recently told me that my AMH is 14. With my previous clinic, I was at 9.6 August of 2020. I'm 33 years old. Can it go up that much after being on supplements for 3 months?
It can fluctuate based on your health, your well-being, the month, the cycle, all of that stuff. Having said that, most centers use an Emulite analyzer from Roche to do AMH. We use an ELISA machine. Our machine is way more sensitive. So it's got a benefit, which is ours is way more accurate, but it's got a disadvantage, which is it doesn't fit the normal scale where everybody else did theirs with that Roche machine. So a 14 with us is kind of like a 9 on the Roche.
Is there a minimum number of eggs you need to proceed with retrieval?
No, I mean, we do natural cycle IVF all the time and we just get 1 egg. So you need 1, that's the minimum. It does depend though. If your body is capable of making 20 and you're only making 3 or even 5, I'm going to stop because I want to get 12, 15, 20. If your body's only capable of making 3 and you're making 2, we're going to go ahead because we're only off by 1 egg and that's not going to make a huge difference. Nor can I guarantee you I have a way of stimulating that extra egg. So it all depends on what your ovaries are capable of and what kind of response we're seeing.
How much more expensive is Duo-stim than a single ER?
Well, it depends on where you go. So I've been learning lately that the other places out there, here's a good sign of how Victory Reproductive Care works, charge more than a single cycle twice to do Duo-stim. So in other words, for example, if the cycle cost was like 11,000 for 1 cycle, then to do Duo-stim, they're charging like a total of 24,000, which is more than just another 11,000. We actually charge 37% less for our second cycle. So it's way cheaper than doing 2 separate cycles because these are people that need help because they're already struggling with bad ovaries. So it should be a little bit less than a full second cycle. But my understanding is everybody else out there is gouging you and charging you more. I know one place in Toronto that I particularly dislike is literally charging people more to do Duo-stim than they are for just paying for 2 separate cycles. That's actually insane. It makes no sense whatsoever. How can you justify doing that? So yeah, I would just say go for, a place where they're going to charge you less. And if you're in Toronto or wherever you are, even in the States, we actually have a patient in New Jersey coming to do Duo-stim with us. So it's way easier to just come here.
Follow up to earlier question about CD8 bleeding during FET cycle.
Yeah.
I go in tomorrow for monitoring. What exactly should I ask and who should I make aware of this?
You want to know what the lining looks like. You probably should get your hormones checked. Make sure your progesterone wasn't high or low or anything like that. Also get a preg test just to make sure something really weird didn't happen. The doctor should be aware of that if you're having a bleed on day 8.
I got 23 eggs, 12 fertilized, but had OHSS bad, had to be drained.
Sure.
So I don't know.
Oh, well, I'm sorry you had to be drained. I'm glad you got 23. I don't know why only 12 fertilized. Maybe they didn't use ICSI, and you'll recover from your OHSS. You should be fine. Just don't do a fresh transfer. That's all.
You are my doctor for the bleeding question.
Oh, well.
CD8 bleeding FET cycle.
Okay, I'll make a note of the name. Let me see.
Yeah.
So I don't read it out loud. Oh, yeah, no problem. We're on it. I will make sure the girls do the right stuff for you tomorrow. No problem.
Go to all Instagram. Have atypical endometrial hyperplasia, currently being treated with Mirena.
Yeah.
Have tried and failed with progesterone and megestrol.
Yeah.
Any suggestions?
No, the Mirena should work. Leave it in for 3 to 6 months. I'm surprised you failed with Megace. leave it in for 6 months, take it out, see what things are like, and then consider doing whatever you have to do from there. But you got to take that seriously because that's a very high risk for cancer.
No question. Just a big thank you for all the information you share with us.
Oh, my pleasure. Thank you for saying thank you. Thank you guys for watching. We really love doing this show. It's a lot of fun for us. Admittedly, we do love to eat. So, you know what we got to do? We got to post pictures of our food. Everybody does that. They post pictures, the pregame. Yeah. Everybody posts pictures of their food. So, you know, we love doing this show. We've helped lots of people. It's very rewarding. Even while I'm doing the show, people are messaging me, telling me how thankful they are that we help them have their babies. So for us, it's an honor. We love doing this. It's very, very cool.
Is birth control similar to Depo-Lupron to suppress endometriosis before an FET?
Not even close. Depo-Lupron is way stronger than birth control. And birth control is not strong enough to properly suppress endo for FET uses. You need not just Lupron, you need Lupron and Letrozole for 3 months to suppress for improving your success rates for FET. We have a video for that too.
At this exact moment in time, those are all the questions I kind of have.
Well, we're almost done, right? Yeah. So, all right. So we'll wind it down. Listen, thank you all for watching. We appreciate you guys being on with us tonight. We will definitely be back again next week. There's kind of a cool article out there about using an algorithm for women that are 43 to 45 to determine whether or not they'll be successful. So I was thinking about presenting that one, but I know not too many of you are 43 to 45 who are watching. So it's still kind of a neat article, and the future is very much algorithm AI based. So maybe we'll look at that one. Maybe we'll do the smooth endoplasmic reticulum and the impact, although that's really technical stuff for most of the patients. They'll be like, what? So join us next week. We'll have another great show for you. Watch our YouTube video coming out on the 5 greatest lies about the COVID vaccine. And it's all about how it impacts your fertility or doesn't. And we'll see you again next week on Fertility Fact or Fiction. Thank you for watching. Have a great night, guys.